Tests for Epiphora. In this video, we will discuss the evaluation of the lacrimal drainage system in patients presenting with Epiphora. We will cover history taking, clinical examination, bedside tests, and imaging modalities used to localize the site of obstruction and assess lacrimal pump function. History is the first step in evaluating Epiphora. Patients should be asked about discomfort and redness to exclude hypersecretion. Drainage failure is typically worse in cold or windy environments. Overflow of tears onto the cheek usually indicates lacrimal outflow obstruction rather than excessive tear production. External examination is crucial. Punctal abnormalities are the most common cause of lacrimal drainage failure. The puncta and eyelids should be examined carefully on slit lamp before any manipulation. Observe for tear overflow from the medial canthus and any mucopurulent discharge. Several eyelid and punctal abnormalities can lead to Epiphora. These include punctal stenosis, ectropion, conjunctivochalasis, eyelashes obstructing the puncta, large caruncle displacement, pouting punctum seen in canaliculitis, centuriole syndrome which causes anterior displacement of the puncta. In children, punctal stenosis and congenital glaucoma must be considered. Palpation of the lacrimal sac is an important step. Reflex of mucopurulent material indicates a mucocele with patent canaliculi but distant obstruction. Palpation is painful in acute dacryocystitis and should be avoided. Rarely, a stone or tumor may be detected. Fluorescent disappearance test. It is a simple screening test. Here, fluorescent 1% or 2% drops are instilled into both eyes and the marginal tear strip is examined. Normally, most dye disappears within 5 to 10 minutes. Prolonged retention suggests inadequate lacrimal drainage. Lacrimal irrigation or syringing. It is performed after confirming punctal patency. If absent or severely stenosed, surgical enlargement of the punctum may be needed. Acute infection is a contraindication for this procedure. After instilling local anesthetic, the punctum is dilated using a punctum dilator. Dilator is introduced vertically, then tilted horizontally while exerting lateral tension on the lid. Then, a gently curved, blunt-tipped 26 or 27 gauge cannula on a 3 ml saline-filled syringe is inserted into the lower punctum. It is advanced for a few millimeters following the contour of the canaliculus and gently saline is injected. Interpretation of syringing. If saline reaches the throat, the lacrimal system is patent. Reflux through the same punctum indicates canalicular obstruction. Reflux through the opposite punctum suggests common canalicular block. Distension of the sac with reflex through both puncta indicate nasolacrimal duct obstruction. The regurgitated material may be clear, mucoid or mucopurulent depending on the contents of the lacrimal sac. During probing, a hard stop indicates that the probe has reached the lacrimal bone and the canaliculus is patent. A soft stop suggests that the cannula stops at or proximal to the junction of the common canaliculus and the sac. It gives a spongy feeling. It suggests canalicular or common canalicular block. Jones dye test. It is indicated only in patients with suspected partial obstruction, where epiphora is present but no punctal abnormality. The patient who tastes saline in throat on syringing. The primary test differentiates partial obstruction and lacrimal pump failure from hypersecretion of tears. In the primary test, 2% fluorescein is instilled in conjunctival sac of one eye. Cotton bud moistened in local anesthesia is placed in the inferior turbinate at the nasolacrimal duct opening after 5 minutes. Recovery of dye indicates patency and is considered a positive test. Absence of dye suggests partial obstruction or lacrimal pump failure, which indicates a negative test. In a positive primary test, dye is recovered from the nose and indicates patency of drainage system, and watering is due to primary hypersecretion. So no further tests are necessary. In a negative primary test, no dye is recovered from the nose, indicating partial obstruction of unknown site and failure of lacrimal pump mechanism. The secondary dye test is performed immediately after the primary test here. The secondary Jones test is done after a negative primary test. This identifies lacrimal pump failure or the probable site of partial obstruction. Here, topical anesthetic is instilled and residual fluorescein from the primary test is washed out from the conjunctival fornix. The drainage system is irrigated with a cotton bud under the inferior turbinate. The secondary Jones test is positive when fluorescein stained saline is recovered from the nose. It indicates that the fluorescein had entered the lacrimal sac and confirms functional patency of the upper lacrimal passages. It indicates partial obstruction of the nasolacrimal duct distal to the sac. The secondary Jones test is negative when unstained saline is recovered from the nose. It indicates that the fluorescein did not enter the lacrimal sac. It implies upper lacrimal dysfunction. Watering is due to primary hypersecretion due to partial physical occlusion or pump failure. Dacryocystography. This involves injecting contrast into the lacrimal passages and taking radiographic images. It helps to localize exact site of obstruction to guide surgery and for the diagnosis of diverticular fistulae and filling defects like stones, tumors, etc. It should not be done in acute infection and if the site of obstruction is obvious, like in regurgitating mucocele. A normal dacryocystography in the presence of subjective and objective epiphora suggests failure of lacrimal pump. However, this is more readily demonstrated by simple irrigation. Nuclear lacrimal scintigraphy. It assesses tear drainage under more physiological conditions than dacryocystography. It labels the tear with a radioactive substance and tracks their progress. It gives less anatomical details as compared to dacryocystography. It is helpful in detecting functional block and lacrimal pump failure, though it provides less anatomical detail than dacryocystography. Sometimes it is also used to confirm the presence of normal drainage such that surgery is not indicated. CT and MRI. CT and MRI are useful in selected cases, especially when lacrimal sac tumors, sinus disease, or trauma are suspected. Internal nasal examination. It is done using endoscopy. It is valuable to detect nasal polyps, deviated septum, or turbinate hypertrophy and is essential before planning surgery. In summary, evaluation of the lacrimal drainage system requires careful history, slit lamp examination, bedside tests such as fluorescent disappearance test and irrigation, and imaging when required. The goal is to localize the site of obstruction and assess lacrimal pump function for appropriate management.